So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Did the intro happen? Hi. Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. I'm so happy to see everyone here in the room tonight, and those of you joining us online, welcome. Happy halfway through Lung Cancer Awareness Month, everyone. It's been quite a month. I'm sure you guys have seen the flurry of activity happening online through social media channels and the like. For those of you who might not be familiar with this program, I'm Danielle Hicks. I am Chief Patient Officer here at GO2 for Lung Cancer. And this program was developed back in 2009, really keeping the person diagnosed in mind and their loved ones, trying to bring to them live and in real time information about what's happening right now in lung cancer across the care continuum. And I am so honored tonight to have Dr. David Gandara here with us. He is a veteran to this living room. He has been doing this as long as we've been doing this, and we could not be more thrilled to have him back here tonight. He was going to be here live and in person, but he started feeling sick, and keeping everyone's well-being in mind, thought it would be best if he signed in to join us in a more safe type of environment. So as you guys know, what we're going to be talking about tonight, we're going to be having a conversation around second opinions and shared decision making. Why both of those things are incredibly important to a person really at risk or diagnosed with lung cancer. So before we jump into that, I want to welcome Dr. Gandara and ask him to tell us a little bit about himself. David, I'm going to switch to you.
Well, thank you, Danielle. And it's great to see you and Bonnie again. I actually think I gave the first living room.
I think you did.
That's my recollection.
Yeah, I think you did.
It's been fantastic to come back there several times. I apologize for not being there in person. But I just returned Sunday night from the IASLC. Some of you know that means the International Association for the Study of Lung Cancer, near and dear to our hearts, from their Latin America meeting called LAUCA, which was in Bogota, Colombia. It was a fantastic meeting. We had several sessions devoted to the topics we're going to be discussing tonight. And you have to forgive me if I cough periodically. That's part of my cold. Because I shook 1,000 Latin American hands and I came back with a cold. 3 weeks before that, I spoke at the National Romanian Cancer Congress in Romania, and I shook 1,000 Romanian hands and I came back with a cold. So this is my second cold of the month. But it's not COVID, and I don't feel too bad, but I didn't want to expose anyone. So who am I? Well, I'm a medical oncologist at the University of California, Davis. Currently, I'm the co-director for a new center there. It's called the Center for Experimental Therapeutics. So this takes drug discoveries, cancer drugs, that are discovered various ways in the University of California system, and it assists that person in figuring out the properties of the drug and studying its pharmacology. It's what we call preclinical. And then getting it into a clinical trial, sometimes finding a partner for that investigator, let's say a pharmaceutical company that is interested in joining with them to develop the drug. So that's a very exciting thing I'm doing. I'm also the chief medical officer, although I wish I was the chief patient officer. I love that term. But anyway, I'm the chief medical officer for another relatively new society called the International Society of Liquid Biopsy. We'll talk about this a little bit later. It's just an exploding field. The ability to study not only the genomics, but immunophenotyping in blood not necessarily needing a tissue biopsy every time. So that's really phenomenal. Our annual meeting there is at the end of this week in Denver. And Danielle, you'll be there, I
I
think.
will be there.
Excellent. Okay, what have I done in the past? Well, I was our associate director at UC Davis Cancer Center for clinical research for many years. I no longer am. I gave that up. I was the director of thoracic oncology, lung cancer. Dr. Jonathan Reese, who's been to the living room, now has taken that. So all of these people who are running the cancer center and Dr. Reese, they used to work for me. Now I work for them. So that's the way life is, and it's a great team there. I also was the chairman of the Southwest Oncology Group, SWOG, Lung Committee. And that is in part how I met Bonnie and Tony and all of you there at what was the Addario Lung Cancer Foundation, now GO2, because we interacted, and I'll never forget when we had our first summit meeting for Alchemy and formed that program. So we have a long-standing relationship. So that's me.
Yeah, that's you, and in the literal nutshell, because there is so much more, and
times 20.
yeah, and to say that Dr. Gandara has been a huge asset to this organization would be an absolute understatement. Some of the things we're going to be talking about tonight, he really pioneered. I mean, he's pioneered a lot of things when it comes to how we look at and treat this disease. But when it comes to second opinions and shared decision making, he really is the cream of the crop. And for those who are fortunate enough to live here where we live or in close proximity to him, we have over the years sent multiple people diagnosed up to him for those second opinions. I do want to say that at the Latin America Lung Conference that Dr. Gandara just got from, we also had a living room there. So we've been doing living rooms there for, I think that Michelle, maybe the last 4 years now. We started right before COVID, then it stopped, and then we started back up again. We were not there in person this year, but Dr. Luis Reyes hosted the living room there in person, and a lot of docs local to the area had their patients come in to be able to ask questions. Michelle was online watching. I did a little video intro. So we love the fact that we're also a part of this type of programming outside of the United States. We have a lot to talk about tonight, so I am going to jump in. I want to remind everybody, those online and obviously you guys in the room, please ask questions throughout. This programming is for you. There are no stupid questions, and they can be personal to you, because the questions that you ask that you think might only relate to you and what you're going through, I am 99.999% sure they relate to somebody else. So please don't hesitate to ask questions as we're going through this. And Dr. Gandara touched on it. Lung cancer is a complex disease. So what do we mean? What do I mean when I say that, Dr. Gandara? Like when thinking about how we treated lung cancer 20 years ago versus how we're treating it now. What makes it complex?
Well, Danielle and Bonnie also know, excuse me, that I like to speak in analogies.
Yeah.
In other words, I like to be able to put complex things in a way that patients can understand them and their caregivers can. And it's not to dumb down the information. It's to put it into context in some way that they say, oh yeah, now I know exactly what you're talking about. Instead of this monoclonal antibody has 3 parts and they have a linker and a payload, you know what I'm saying? So, I talk about stealth bombers and I talk about molecular fingerprints and all these different things. So when we talk about lung cancer being a complex disease, the very first living room I ever gave, and I don't even remember if it was broadcast then, I think it was being recorded, but at any rate, I looked into the room and I said, how many of you have lung cancer? Because, first thing I ask is, how many kinds of lung cancer are there? And somebody in the audience said 2. They were thinking about small cell lung cancer and non-small cell. And then somebody else said 4, and they were thinking about adenocarcinoma and large cell carcinoma and so forth. And then I said, how many of you have lung cancer? And a bunch of people raised their hands. And I said, well, that looks like about 30. That's how many kinds of lung cancer we have in the room tonight. But if we had 100 patients here, there would be 100 types. And the key and the message, of course, is that everybody is an individual, and the complexity of lung cancer brings it down to what we call personalized oncology. In other words, that we want to know as much about that cancer and the patient as we can, and then design a treatment for them, not just pull something off the shelf. And so that brings me then to molecular testing, which is now a standard of care for the last 10 years. Before that, less than 20% of lung cancer patients were having the genomics of their cancer. So not your normal genes, but what's in that cancer. Less than 20% were getting that assessed. Now it's up to 90%. So we've come a long way. And then patients ask me, what does it mean? When you say you're going to test the genetics of my cancer, what does that mean? And I say, you know your fingerprints. Nobody else has a fingerprint like you. Well, we want to get your molecular fingerprint that identifies your cancer and allows us to treat it personally. And of course, now we have not only chemotherapy, which we've had for a long time, but targeted therapy against one of those genes. So I think many of you in the room will know EGFR or ALK or ROS1. And now at diagnosis, the guidelines say that if you're a lung cancer patient, stage 4, that you should get tested for at least 9 of those oncogenes, particularly if you have what we call an adenocarcinoma subtype. And that's basically means that almost everybody is going to get tested. Even if it's a squamous cell lung cancer, we know that some patients, particularly those who are light smokers or never smokers, they can have those same oncogenes. And when I first proposed that 15 years ago, some of my colleagues said, no, you're wrong. That never happens. Well, we proved that it does. And in China, 20% of the people with squamous cell lung cancer have an EGFR mutation. So then we have immunotherapy. Well, how do I explain that to my patients? And I say, you know, the immunotherapy doesn't kill any cancer cells. And they're all kind of amazed. They say, well, how do the cancer cells get killed? And I say, all of a sudden, your immune system wakes up and it says, oh my God, there's something bad here. I better take care of it. Just like it would if you had a virus. If you have the flu, your immune system reacts. That's why you get fever and chills. That's part of the immune reaction. So all of these things that we have today mean that we have literally hundreds of different options for an individual patient. Do they have one of these mutations? We call those oncogenes. What kind of cancer is it? Meaning, is it even a small cell lung cancer? Now we're actually molecularly classifying small cell lung cancer. And for the first time in history, in a month, we're going to open a trial in SWOG that individualizes based on the genomics of that cancer, part of their treatment. So that's a long explanation, but I think that tells you the complexity.
I think you're right. I think it does tell me the complexity, and those that watching the complexity. And a little side note here, you were in fact the first one to come and speak live in this room. And also, back then you used your bus driver analogy to explain targeted therapies. And I had to tell you, I stole that from you and just used it last month. Of course, I gave you credit, saying a very dear friend of mine in the foundations taught me this way to explain it. And I've explained it that way so many different times to so many different people. And it allows folks to have this aha moment. So as far as the analogies go, bring it on. And I couldn't agree with you more. Like we just touched on, and for some of you who are veterans to this meeting, having come and been listening to this as these things have progressed, particularly over the years, we have come so far. and things, when I say this is an ever-changing field, I don't even think that necessarily covers it. What we said a month ago might be different today, and we can use immunotherapy, Dr. Gandara, right, as an example of that. People who didn't express something called PD-L1 before were thought not to be able to respond, and now we have treatments that are for those sort of non-expression of this type of biomarker, that there is a drug available for them. So I just think it's so important, and we say this all the time, and this is going to be part of our conversation tonight, is around this patient and caregiver empowerment. And it's not easy because it is complex. We're here to help you. Folks like Dr. Gandara are here to help you. And so with that, let's talk about, if the complexity that we just described wasn't mind-boggling enough, I think what we're going to talk about next will explain why what we're talking about next is so important, and that's second opinions. You guys have heard me say...
Can I interject something else first?
Yeah.
Danielle? Okay. So the other part of the complexity is, how did I get this lung cancer? And we spent several sessions on this at the Latin America meeting last week. And I think this is something every patient wants to know, particularly someone who never smoked, and they get lung cancer. And so when we talk about complexity now, we're talking about environmental exposures, occupational exposures, smoking, secondhand smoke, and that person's genetics, their normal genes. And the reason I think this is really important for those of you that are caregivers or patients in the room is, very often I have a patient who comes to me with what we call a never smoker cancer, like EGFR out. And they say, my father smoked, and I'll never forgive him for this. He probably gave me this lung cancer. And I said, your genetics say he didn't. And I'll tell you what, I have a big beef with the American Cancer Society. They basically say everybody got it due to some smoking exposure, and you probably got it from your parents. They're totally wrong. They won't give up on this. So if you have a never smoker cancer, that means the genetics, you don't have the mutations in your cancer that smoking causes. It didn't do it. Instead, and this is bad, and I think some of you know this, just within the last 2 years, we have very definitive proof that air pollution, particularly for the people who've never smoked, is an issue. And there's fantastic work. Danielle, I think you and Bonnie were there when we gave the Addario Award, which is another thing. It's this fantastic award. We gave it to Charles Swanton from the UK, from what's called the Crick Institute, because he's the one that found out that various components of air pollution, they call them PMs, or particulate matter, little microscopic particles, get into the lungs of people and they can promote lung cancer. But only if you're genetically predisposed. That doesn't mean your race or ethnicity necessarily. It means just something, your normal genes, just your carrying. It doesn't mean that it's hereditary either. So when I tell people this, they say, oh, well, what about my children? It's not that kind of heredity. It's not like hemophilia or something like that. But the reason I talk about this is it's important to know what stage your cancer is and what the treatment's going to be. But very often people have no conversation about, how did I end up with this? And so now we know a lot more about that.
I applaud you for that, and I'm going to timestamp that because I think we need to make a little clip and just talk about that all by itself and push that information out. And I feel like, since I started doing this almost 20 years ago, from a people who smoke standpoint, I think the statistic was and still is, only 20% of smokers will ever get lung cancer. 80% of them will get heart disease, right? But we're not talking about that. We're talking about the 20%. So why aren't the other 80% developing lung cancer? There's more to it than just the smoking factor. And of course, air pollution, and when I think about our veterans and I think about their chemical exposures, their burn pit exposures, all of those other things that factor into it. And I think we are just at the sort of the cusp of really understanding the why. And it's important in the how, because people want to know all the time, how did I get this? Why me, right? And so opening up that doors, I think, is incredibly important. And as you guys can see, why we have people like Dr. Gandara coming and talking about this type of thing. So complexities, second opinions. We talked a little bit about the comprehensive biomarker testing. And although it is in the guidelines and it should be doing, it should be happening, we know that it's still not 100%. And we know that particularly in small community settings, small rural community settings, it's still not always happening. And things are changing fast. It used to be for the late stage patients, those were who we tested. Now it's early stage because things have changed, right? Data and research have shown us it's important to also do it here. You guys have heard me say this over and over again too, those sort of small, rural, general oncologists are expected to know everything there is to know about every type of solid tumor and blood cancer that walks through their door, which in the day of personalized and precision medicine is really unreasonable, which is why second opinions with doctors like Dr. Gandara are so incredibly important, because he has the benefit of being able to specialize, being able to hyper-focus on 1, 2, or 3, different types of cancer instead of the 100 and change different types of actual cancer that are out there. So, Dr. Gandara, let's talk a little bit about second opinions. Let's talk about the when, the why, and the how.
Well, I agree with everything you said, Danielle, but I think just like we talked about lung cancer is complex, second opinions are complex.
Yep.
And they're not just for somebody who's in a small rural community where there's a general oncologist. And I want to emphasize that, because some patients feel like if they go for a second opinion, that's showing distrust in their oncologist. And I almost never in my entire career had an oncologist who was not supportive of a patient going for a second opinion. And it doesn't matter how, even people who specialize in lung cancer, we do this all the time. I send some patients to Stanford to Heather Wakely for second opinions. She sends them to me, et cetera, et cetera. So the worth of the second opinion is being able to get somebody who you're a blank slate to them. They start over from scratch, and then they tell you maybe things that your oncologist never did, no matter how good they are. Maybe they also tell you, I agree with everything that's being done, and here's why. So they also maybe help explain it. Or they say, I think this treatment is fine, but there are also some clinical trials in this area. And maybe your institution, wherever it is, whether it's a university, whether it's a small rural or whatever, maybe it doesn't have those trials. So that's an additional benefit of a second opinion. When to get a second opinion? Almost any time. Sometimes at diagnosis, sometimes at the time you've had your first kind of what we call course of therapy, meaning the kind of treatment, and now the cancer has started to become resistant. Sometimes I get a second opinion because the patient says, I'm in a complete remission for 3 years, and the doctor's trying to figure out whether I should just stop the treatment and we should just keep an eye on the scans. So there are all sorts of opportunities there.
Yeah, I just want to kind of reiterate what you just said. So second opinions can, and point well taken, it's not just rural general oncologists, it's expert against expert, because the good ones never claim they know everything all the time, right? They're like there's always going to be somebody right? And you taught me this a long time ago. There's always going to be somebody smarter than me, and especially when we talk about building teams, like hire people smarter than you. You know, people that don't know what you know, but know something we need to know. So second opinions can confirm your first opinion, so give you that sense of, okay, I'm on the right path. They can help you to consider and explore other potential treatment options, including clinical trials. And one of the things we didn't talk about was palliative care, because I don't think that's talked about near enough, but how important that is in whatever treatment plan you're going to start. Help you feel more comfortable with your healthcare team, because sometimes, honestly, even though people may be getting the best right first answer, there's a disconnect between the healthcare provider and the person who is actually having to walk the walk with the treatment. So I think all of those things are important to consider. And then I think the other thing is healthcare providers like Dr. Gandara, who he and his team are going to help you with access to resources and the support outside of just the clinical stuff that you may need. That's also, I think, a big part of treating the whole person. So, go ahead.
Can I expand on this a little bit, Danielle?
Oh, yeah. Yes, Dr. Gandara, please expand, and then we got questions. He just wants to expand.
Yeah, so I just wanted to also say that part of this, and I don't know if you were going to get to this later, are you going to talk about video visits later or
Yes.
not necessarily?
Yeah.
Okay, I'll wait then.
Okay, okay. I think, Bonnie, pick up your mic.
I was just going to say, don't ever, ever, ever be ashamed or have a problem with telling your doctor you're going to get a second opinion. Mm-hmm. Don't ever, ever, ever worry about that, because you're important, and that physician may have something that you haven't heard yet.
Yep.
And I know most of you here in this room have had a second opinion in some form or fashion, and the newest patients don't know even about second opinions, right?
So it's important that we're talking about it.
Yeah, so it's
agreed.
important that we're talking about it.
I think
Absolutely.
Evie has a question too.
I wanted to ask you a question about, I always have gotten second opinions, as did my husband, and I love a second opinion that just confirms the first opinion. It makes me feel like, okay, this is good. The problems I've encountered have been when the second opinion is very different. So I don't know which one should I'm sure they're both good opinions, but let's face it, sometimes there are choices, but I'm not the expert. How do you make a decision based when you've been given two different paths to go down for treatment? That's where it gets very challenging, I think, for a patient and for a caregiver. The question, so now do I go with the third opinion? How would you deal with that situation?
Yes,
Of course, that's a
Gandara,
great question. Do you want me to chime in first, or Bonnie, did you want
No,
to make
go
a
ahead,
comment?
Dr. Gandara.
I just wanted you to talk to what she had to say.
Yeah.
Okay, so I think the first thing is communication. And when I say communication, I'm not talking about with the patient in this case. I'm talking about between the doctors. So when I do a second opinion, it doesn't matter if I totally agree, partially agree, disagree. I try to communicate with that treating physician, because it's a second opinion. I'm not the treating oncologist, right away. And this is even before they get my report, which sometimes takes a while, especially if they don't have care everywhere. We have to fax it to them. And I say, here's what I'm thinking, and here's why. And sometimes they say, oh, you don't know about the new CT scan of the such and such. And I say, oh, well, that changes my opinion.
Yeah.
Or they say, I didn't know about this new trial that opened up this, or I didn't know there was a way to now get a liquid biopsy in this patient and help sort out what to do next. But I think almost always that treating physician, as long as the second opinion doctor treats them, respects them as a peer, they're very amenable to work with that referring physician. And I actually have a large number of patients who come to see me for a follow-up second opinion every 3 to 4 months. And after they get the scan, and then I go over it with the treating physician, and jointly we decide what we're going to recommend for the patient. Now, at the time of the visit, I'll still tell the patient my opinion. And I'll say, you know, I think we really need to consider such and such in your case. So it's not that I'm withholding information, but I'm also trying to close the loop so that that physician isn't blindsided. In other words, what if the patient comes in and says, you know, Dr. So-and-so said that the treatment you're giving me is terrible and recommended that I switch to something else. So in other words, what we want to do is we want to be a team. And part of the team is the other doctor, and part of the team is the patient and their caregiver. So I'm not sure if that completely answers your question, but I think it's something that, you know, 99% of the problems in life are communication, I think.
Yeah.
I think communication can solve a lot of those issues.
Yeah.
I think also that I've always gone for second opinion at the start. And so before I even let anybody treat me, and sometimes the person I went to for the second opinion is the person I wind up getting treated by. So that's another, I think, benefit of getting a second opinion, even if the two opinions were the same. So thank you.
Yeah, I think it's interesting, and I think it's a really great question, Evie. I think, yes, Dr. Gandara, I think you answered it very well. I think you are what good looks like in the second opinion space, right? Where your willingness to work with local, you know, oncologists to collectively come up with a plan that's best for patient A, B, C, or D. I mean, I think unfortunately that doesn't happen all the time, and at least we hear that doesn't happen all the time. Quite often we hear at the mere mention of a second opinion, somebody's doctor has lost their mind about it, right? And so I think that's a rule that GO2, the patient support services team in particular, can help talk people through, because it shouldn't be that way. The way Dr. Gandara just described it is what it should look like. So continuing on the
I'm sorry, can I chime in once
yes,
again?
of course.
So Bonnie and Danielle know I'm not shy. So I think if your oncologist tells you, I don't want you to get a second opinion, or they get upset about you getting one if it was a self-referral, if you went on your own to get it, I don't think that's a good sign. In other words, that's not part of the doctor-patient relationship that I think is on the right track. All of us, and you know, when Danielle said maybe somebody's smarter than the other, I don't think it's smarter necessarily. But you know, when we talk about getting people together and new ideas come up, you know, no one person can think of all the points that might need to be made. So I would say that most oncologists that I've dealt with welcome a second opinion, even if they're very confident in what they do.
Yeah.
And if they don't welcome the second opinion, I'm a little concerned.
Yeah. Suspect. Yeah. Ditto, ditto, ditto. You're getting some very quiet golf claps around the room right now for saying that. And I know we're not talking about tumor boards tonight, so I don't want to go down a rabbit hole, but it's a perfect example of a tumor board, right? You get all of these brilliant minds together coming up with a treatment plan for a single person, because, I mean, the more the merrier. So let's continue down this. We've got so much to talk about. Second opinions, if you're here and you live where I'm sitting right now on the peninsula, we have fairly close access, we're in close proximity to Stanford, to Davis, to UCSF, where you can get second opinions with people like Dr. Gandara, who have the benefit of specializing in lung cancer. That's not the case for a large majority of the people in this country. So enter telehealth, which became very popular, particularly at the beginning of the pandemic, right? And so, Dr. Gandara, can you talk about some of the benefits, but also some of the challenges around the current ability to use telehealth for second opinions?
Well, Danielle, I think you've already brought up the key points, is that telehealth seemed to be accepted by everyone during COVID for obvious reasons. But then once COVID, I don't want to say COVID went away because it hasn't gone away,
No.
but once the crisis part of COVID seemed to be decreasing, insurance companies cut out telehealth. And it's unbelievable that they would do this because it's cheap. In other words, a lot of the cost for going in person and seeing a physician is the facility fee. And that means they charge you because you're using a room and you're using a nurse and they're taking your vital signs. And then you have administrative people who are checking you in and out. And so when you do a video visit, none of those costs appear. And so the video visit is about a third as expensive. And yet insurers are trying to cut them out in many situations. So why? It's part of what's called churning. And I think many of you in the audience have heard of this, about they figure if they say we're not going to reimburse for telehealth, that you'll have fewer visits. In other words, because you won't go in then, you'll wait or something. So this is a real problem. The other thing that they did is during COVID, insurers said anywhere in the United States, if somebody wants a second opinion, video visit, you can see them. As soon, about a year ago or a year and a half ago, as soon as COVID started going down, they all of a sudden said, if you're going to see a patient in a video visit, you have to have a license in that state. So in other words, even somebody who wants to come to see me from Reno, I cannot see them as a video visit. They have to physically come to me. So here's the other thing that I didn't mention, is that I'm an adjunct professor at the University of Hawaii Cancer Center. Mm-hmm. And I have this large interaction for many years with them. I actually helped them. I put in the shovel in the ground at the land breaking for their cancer center when it was being built. At any rate, so when they said you can't see any more patients because I have a great relationship with many of the oncologists there, I said, okay, I'll get a Hawaii license. And I did. So every week I see at least one or two patients from Hawaii by video visit. And I work with the local oncologist there. And because in Honolulu, there are no lung cancer specialists. There are no breast cancer specialists. They're all general oncologists. And they are very happy to have somebody interacting with them, and the patients are happy. So it's a good all around.
I couldn't agree more. And it feels so incredibly ridiculous, quite frankly, to me, this whole licensure issue. When we think about the guidelines set forth either from the NCCN, right? Those aren't guidelines just for California or just for Texas or just for Hawaii. They are the guidelines, right? And so to say that a doctor who is following these guidelines and providing quality standard of care to their patients can't do that 2 hours away from Sacramento and Reno, like is asinine. And I don't claim to have the answers about how to effectively change that. I think people, voices like yours, people being angry and upset about it and making noise is something that could actually help. We do have another question, so I want to jump to that.
Hi, I wanted to find out about tumor boards. Is that typical that a patient coming in for the first time, their case will be discussed by a tumor board, or is that certain circumstances that happens?
That's a good question.
Well, I think the first thing I would say, and then I would be happy to have Danielle and Bonnie chime in because they know a lot about tumor boards, is that you cannot physically present every single patient in a tumor board, even if about the most frequent. In ours, it's weekly. So, and UC Davis, we're big enough that on Tuesday, it's a breast cancer tumor board, and on Wednesday, it's lung cancer, and on Thursday, it's GI cancer, et cetera. However, we may have 20 new patients that week in lung cancer. And so what you usually do at a tumor board is you either present somebody where you're having a hard time figuring out what to do to get, group think, or you present a patient who might be a candidate for a clinical trial, and you want to see what other people think about the eligibility. And the person who could help you with that might turn out to be the radiologist, because you're trying to figure out, is there a metastasis here or not? Or the pathologist, is this a mixed kind of cancer, and what's the genomics? And so that's the group think. Then also lung cancer, compared to lots of other cancers, in many, many cases, it's multimodality. And what we mean by that is there's a role for the medical oncologist like me, there's a role for the surgeon, there's a role for the radiation oncologist, et cetera. And so you're presenting the case to the tumor board where everybody can chime in. And then the surgeon and the radiation oncologist can say, yes or no, this is a case that might be a candidate for surgery, for example. But you can't present every case. And I know that's maybe not what you want to hear, but I'm just saying on a practical basis. And so if it's really a clear-cut case, then we may not present it.
And I think it is.
UC Davis, also the physicians are very happy to present their cases.
Yeah, and I think it is.
Again, just going back to what Danielle said, in some places, maybe if the person is not confident about their decision, they don't want to share the case. So it's a mixed blessing.
Yeah,
but tumor boards, we now have molecular tumor boards. So anyway, it's even more complicated.
Yeah, it is more complicated, and I think you're right. When you think about the sheer numbers of people in the U.S. alone that are diagnosed every year, you can't send every one of them through a tumor board. And I think some cases are more difficult than others. Some feel more clear-cut based on, as long as they've had the proper upfront diagnostics to understand what Dr. Gandara was saying at the beginning of this. What does any single person's individual cancer look like? And other people, it's not so easy. So I am being mindful of time. I know we started a little late, and we're probably going to run the full hour, which only gives us another 20 minutes.
But we're going to get David to come again and come in.
Yeah, we'll have him come in for sure. But we're not done yet.
No,
so
I'm just...
you're greasing the pan. So to kind of close out this, we could have spent the whole hour talking about the importance of second opinions, but the bottom line, and we'll do some final remarks at the end, is second opinions are important, and they're important at any time during the experience of a diagnosis with lung cancer. I will, put myself and our patient support services team out there as saying we can help facilitate those second opinions. If you don't know where to go or where to turn for something like that, we are here to help you do that. But I think this moves us in.
I just wanted to add on to what Danielle is saying. It's so important, those second opinions.
Oh, your
and
mic.
all of these things. It's so important, and all of these things that we've talked about tonight, they're really, really important.
Yeah.
And for you to come here and ask, what's a second opinion, or what is all of these things, we can explain those things to you and help your physician. It's so important that we grab onto you and get you going.
That's it. So now I want to jump into shared decision making. You guys have also heard me talk ad nauseum about the importance of this, about the person diagnosed, as well as their loved ones, their care team, their care partners, being empowered and educated and part of this decision-making process. So, Dr. Gandara, when you say shared decision-making, what do we mean? What are we talking about?
Right. So there's actually been a lot written about this, not necessarily just in oncology, but in medicine in general. And the people who write about this talk about different models. So the classical model for physicians is the patient comes in, you've got the diagnosis, and you say, here's what you're going to get. Here's what we're going to do. And the patient doesn't have much input. The second model would be that you discuss all the issues with the patient, but then you say, here's what I'm going to do as a physician. And so although the patient understands a lot, they're not really part of the decision making. Those two models have gone away largely in the United States. The third model, well, actually, there are four models. The third model would be that the physician explains everything they think is important to the patient. And then they say, here's what my recommendation is. And they see if the patient agrees. And the fourth model would be that the patient is the one who makes the decision. And the physician says, here's what is my first recommendation. If you don't want to do that, here's my second. If you don't want to do that, here's my third. But I'll tell you what, for those of you that are patients and caregivers in the room, you know that some patients say, Doc, you know, I don't know anything about this disease. You told me about this molecular fingerprint and so forth. I want you to make the decision. And other patients, you know, have researched out their cancer. If it's got a mutation, they know as much as they could learn about it, and they really want to guide their treatment. Now, sometimes the patient says, I want drug X. And you say, you know, that's not your best option because of this and that. You know what I'm saying? So you still try to help the patient make a good decision.
Yeah.
Or they may say they want to go to Mexico and get coffee enemas. That's always a bad decision.
I mean, I think what you're saying is so important for a lot of reasons. A, when I say empowered patient, I don't mean you feel empowered because you saw a commercial on TV that said XYZ drug is the drug for lung cancer patients and you think that's the one for you, because as we've already sort of at high level anyway laid out, not all drugs are right for all people. And then there's the snake oil and the coffee enemas and all of that. And I think being part of the decision making, and I think about goals of care, and I think about this a lot because when my mom was diagnosed almost 2 years ago now, nobody asked her what she wanted. They basically said, go home, get your affairs in order. And obviously, I'm not going to tell the whole story again. I mean, if you haven't heard it, call me. But through a series of incredibly serendipitous events. But I think the turning point in your treatment pathway was when one of your healthcare providers said, Bonnie, what do you want to do? And she said, I don't want to die because I did nothing, right? Which was basically her first option. And here she is today because somebody actually listened to what your goals were. Your goal was, maybe I'm getting out the other side, maybe I'm not, but I'm not going to die because I did nothing, right? And so I think listening to people is important. Larry, I see you have a question.
I've had the good fortune to receive 3 or 4 now second opinions from Dr. Gandara, and one of the great...
I don't know if he can see you or not.
It's okay.
Okay.
One of the great things that he did for me a couple of times was give me 2 or 3 options and say, there's no bad answer, which enabled me to be part of the decision-making process.
Yeah, I think that's really relevant too.
Thank you for that comment. Appreciate it. Good to see you.
Yeah, I think that is an important part of it too, right? And Dr. Gandara, I know I've asked you over the years, like, because a lot of times there is more than one right answer. There's more than one acceptable choice, and being able to understand what those choices may be and being able to talk through what that looks like, I think are important. Just a quick show of hands, like, and Michelle, I'm sorry, I haven't asked you online, we're good, of people who felt like they were part of their the decision making in their treatments. So maybe half the people in the room. Yeah. I mean, I think, well, it's better than none, right? I mean, I agree, but I think that's why we do this programming, right? To allow people to feel empowered. So really, in a nutshell, being able to understand that, understand your diagnosis, take an active role in those healthcare decisions and the management of your care, which means, and I'm reading this because I don't want to mess it up, understanding your diagnosis, your treatment options, and any potential side effects, right, before you start your treatment. Having access to reliable information. Dr. Google is still, even in the state of AI, I don't think the best place for anybody to go to fully be able to flesh out and understand what their particular diagnosis may be. I'm going to reiterate again, access to palliative care. I know this conversation tonight is not around palliative care, but I will scream it from the rooftops. And information on clinical trials is all part of this sort of tete-a-tete, head-to-head, mouth, I was going to say mouth-to-mouth, that sounds weird. These conversations that you, as the individual diagnosed and your healthcare provider, can have together about what is the best decision for you. And going back to second opinions, again, now I'm hopping all over the place, but I think it's something we didn't talk about enough is the clinical trial experience and how important a role that is for a lot, if not most, people currently diagnosed with lung cancer, which is still people being diagnosed in the later stages. Clinical trials are an important option to consider and to have conversations with your healthcare providers about. And again, if Dr. Gandara is your healthcare provider, clinical trials are his, he eats those for breakfast. Like, he knows everything that's happening right now, not only in the approved space, but what does the research look like? Like, what is this data showing and what might be best for my patient? Not necessarily the case with a general oncologist. So again, shameless, not so shameless plug for GO2. We do also have support through our science and research team where we will one-on-one navigate folks through their diagnostic testing, their biomarker results, and then help them to find clinical trials that may be appropriate for them to then go back and talk to their healthcare providers about. So we can also provide that type of service for folks who may not be having those conversations with their healthcare providers.
And that's why we're here. That's what we do.
Yep. So let's talk a little bit, because I know we're getting close on time and I want to get back to acknowledging LCAM at the end of this, but what do outcomes look like when good happens, right? So whether someone comes to someone like you, Dr. Gandara, first, and or comes to you for a second opinion, and that shared decision-making conversation is happening, do the outcomes show anything different than when maybe those things don't happen?
That's a great question, Danielle. And one of the good things, and you brought this up earlier, is when you're supposed to be the expert in something and don't know the answer, you should tell them, I don't know the answer to that. And I do this all the time. And so even at this meeting in Boca, Colombia this past weekend, I gave this talk and somebody asked me a question where I didn't know the answer. And I said, well, I don't know the answer to that. I said, do you know the answer? I said, what do you think?
Yeah.
And they said, yeah, actually, I found literature on this, blah, blah, blah. So I don't know the answer to this. I know, for example, that there have been very good studies that show that a cancer patient on a clinical trial has better outcomes than the patient getting the very same therapy off the trial. Well, why would that be? And it's because the clinical trial has a protocol that needs to be followed in terms of how do you give the treatment? What do you do if there's side effects? When do you get the next scan? And so it's a really organized way of giving that treatment, which might not be what would happen if the patient wasn't on the trial, even with the very same treatment. So I know those data, but I'm not sure if I know the answer to your question. What do you think?
I'm about to tell you what I think. And it's not because I'm so smart, I figured this out all by myself, but there is research and data to show that when you are headed in the right direction and you have a healthy, productive, cross-collaborative relationship with your healthcare provider, that there are earlier detections of potential complications, right? We talked about side effects earlier, and about the need to stay on top of those things. If you know what to look out for, you know when to report them before they get out of control. We know that treatment adherence, so people adhering to what their treatment plan is better when they have a better understanding of the what, whys, and hows behind the treatment plan that they're on. They have a better understanding of lifestyle modifications, and this is a very personal one to me because of this beautiful lady sitting next to me. And we know that people with lung cancer quite often, more often than not, have pulmonary function issues. She definitely does above a certain elevation, which includes getting on airplanes, which are pressurized to about 8,000 feet. So if she doesn't know that and she gets on a flight from here to Europe and she's in the air at 8,000 feet for 11 hours without oxygen, that's a problem, right? So you're more likely to understand those types of things. You have improved access to support, and not just potentially financial support, but psychosocial support. All of those things that are outside of the clinical sort of space in your treatment. How do we help you reduce anxiety and come up with tools for coping with the whole mental aspect of being diagnosed with lung cancer and how that impacts the rest of your life. And all of this, like if I could package what good looks like in some way and just literally like silver platter it to everyone diagnosed, I would, because I think it's important. And I think there's data that shows that when all of these things happen, when all the stars line up, that there is improved progression-free survival, improved overall survival, and for sure improved quality of life, because we're looking at and paying attention to the whole person. So that's my spiel.
Danielle, can I chime in here?
Yes,
again?
please.
Okay, so I'm so glad you brought this up.
Yeah.
Because part of my research is on an area that some of the patients in the room or online may not have heard about, and it's called PROS, or patient-reported outcomes.
Yep.
So this is a big part of oncology clinical trials now, and the FDA, for approval of a new cancer drug, likes to see these things incorporated in the trial. So what do I mean? What I mean is that there are several validated scales that we can use to gauge how's the patient feeling.
Yep.
And there are two kinds. One is functioning. What's your level of physical functioning? What's your level of social functioning? Are you able to maintain a job if you were working? All of these various things, and they're built into a scale. And the patients on the clinical trials these days, and this is part of a huge immunotherapy trial that I'm associated with, we did these. And the second kind of tool was on symptoms. Is my breathing better now than it was when I started the clinical trial? Is it worse? What about pain, et cetera, et cetera? So I'll just tell you very briefly. We just submitted a publication, which I presented at the World Conference last year, that said these patient-reported outcomes were much more accurate than other things in predicting the survival of the patient. And even things you probably know, some of the patients in the room probably know about performance status. We call it PS. And the typical scale, if you're a 0, that means you have no physical limitations, et cetera. And if you're a 1, you have some mild ones, and a 2, you have more, and so forth. So what we found is that these patient-reported outcomes were more accurate than performance status as determined by the doctor in predicting survival. And this is incredible. And then we started, well, what if we combine this one with this other one? And so we've actually made a proposition that so-called composite patient-reported outcomes be used in evaluating a drug. In other words, how does it perform? What does the patient think if they're on, let's say, a randomized trial of the new treatment versus the standard treatment? So I know maybe that's a little off key here, but I think it's important for patients to know that the patient voice is increasing dramatically in clinical trials. And Bonnie helped to start that trend.
Yep.
You know
And the mic.
Oh, I'm sorry. There is so much information that each patient has, when they're diagnosed. And it doesn't matter who is diagnosing you or who is going to be taking care of you or whatever. But once they start, if they can just start asking the patient, what are you feeling? How have you been? Have you had any, whatever? It's so important.
I agree. It makes all the difference in the world. And I'm actually really glad that you brought up patient-reported outcomes, because I jumped on that train a long time ago. And I think some of you may know we have a lung cancer registry, another shameless plug, lungcancerregistry.org. It's an unbranded platform where there are, don't quote me, but I think 10 different surveys in this registry. One is a baseline, just who are you, what does your diagnosis look like, some of the how are you feelings, all of that. But they really run across the board. And then when I think even, and that is how you can lend your voice. And sometimes it feels like, oh man, you just want me to sit and answer all these questions. You don't have to do it all at one time. Sit down, have your cup of coffee, take a little bites out of it. But I even think about the epidemiology of young lung cancer study that's been ongoing for quite a few years now. But it is also one of those things taking that deep dive approach, because to Dr. Gandara's point, what we can learn, what science can learn and find out from you and your experience, not just now, but before now, is incredibly relevant in how they are designing and researching the trials and studies that they're doing right now. I mean, I think I just can't. And there's even we have a caregiver survey. This is one that I think is really important too, because the unsung heroes, I just gave this big talk about it at the gala a few weeks ago. Caregivers are the unsung heroes and have their own sets of needs, right? And I see caregivers hugging across the room. And I think the more we can understand that experience, the better we can help you too.
Yeah, absolutely. And I just wanted to drop one more thing. You mentioned it a minute ago. Young lung cancer. Nobody was looking at young lung cancer a couple years ago. They're still not looking at it, David, as often as they should be looking at it. But there is such a thing as young lung cancer. And, we have to jump on that and start working on it the way we're working on it.
I agree, and I think that goes back to where Dr. Gandara opened this conversation, right? And I too am mad at the ACS, by the way. But this conversation opened with this perception about who and how people get lung cancer being so misunderstood and so misguided. And young lung cancer is a perfect example of that. And I think, although people are still being like, you were only a year older than I am now when you were diagnosed. I know, I won't tell anybody. But you were still misdiagnosed, I guess my point, for almost 2 years.
Multiple
but
times.
we meet, 20-something, 30-something, 40-something-year-old people all the time who were like, yeah, no. Even when I suggested that this could be something more serious, the docs are like, no way, you're 35 years old, right? So it's important. I know. Okay, so before we get to our shine a light moment, Dr. Gandara, what do you most hope people take away from our conversation here tonight?
Gosh, Danielle, you put me on the
I'm
spot.
getting really deep. I'll give you a namaste
I
after.
think sometimes you want them to have to take in the whole enchilada.
Yeah.
And what I mean by that is everything we talked about is important. If you put it all together, it creates a framework for the patient and the patient caregiver to interact with their physicians, to be self-motivated, to learn about their cancer and why it's different from the other people in the waiting room, and to participate in the decision making, and to know that the patient voice is incredibly important and is increasingly being listened to. So that's my little over-the-top summary. I'll end by one of my favorite quotes of all time, which I use all the time, which comes from Bonnie.
Uh-oh.
And that is the right treatment for the right patient at the right time. That's personalized medicine, isn't
Yeah.
it?
It's just that simple. I mean, it really is complex, but when what needs to get done needs to get done. That is exactly it. So before we close out, and in honor of Lung Cancer Awareness Month, and in honor of my colleague Katie Morello, those of you in the room know who she is. She's not here tonight because she too is not well, although she's really, really, really not well. Katie had taken on our Shine a Light program a few years ago now. Jen's also not here to tell me exactly how long it's been, but she has really taken our Shine a Light program to a new level. So for those of you who don't know what Shine a Light is, this is our 16th annual event. It's the largest coordinated Lung Cancer Awareness Month program in the world. As of today, we had 253 Shine a Light events taking place across the country. It really provides a voice for tens of thousands of people, provides education, support, and hope. And I'm proud to say that we are shining lights in all 50 states. It is a healthcare center, healthcare provider, patient group, patient advocate, caregiver experience where people are just agreeing to, if it's a healthcare center, for example, host a day in their healthcare center where they are shining a light on lung cancer. They're making it important. They're getting people like Dr. Gandara or somebody on staff to come down and talk. They're inviting patients and caregivers to come and learn. They're providing education materials, all of that sort of thing. But not just in all 50 states. I think it's in 3 different countries as well. Katie, if you're watching from home, I'm very sorry if it's more than 3. I will correct myself online after. But what I'm going to ask everyone to do, as Katie, if she were here, she'd be standing right in the middle of the room, maybe doing a cartwheel for you there. And everybody should have flashlights. These go out as part of the toolkits to all of our lung cancer Shine a Light. Oh my gosh, I don't even know how to turn mine on. Please don't ask me how to turn it on. Oh boy. Oh, here it is. Oh.
There you go.
Well, sort of. Oh, there it is. And we're going to turn out the lights. And Katie wrote this for me, so I'm speaking on her behalf. In this moment, we invite all people living with lung cancer and survivors to please stand up and shine your light. Nobody needs to stand up if you don't want to. If you're a caregiver, a loved one, or anyone impacted by this disease, please also shine your light. As we shine our lights, we celebrate all that are surviving and thriving. We remember those we have lost and honor everyone who has been impacted by lung cancer in our community and across the world. Our lights are a symbol of progress, support, and hope that is created when we come together. Thank you for shining a light with us. So thank you all. I feel like I'm at a concert. Thank you all for participating in that with me. And then, of course, I want to give a huge thank you to my first favorite, Dr. David Gandara, for coming and talking to us tonight. And we will absolutely get him back down here in 2025 in person. I know, I know some of you were looking forward to meeting him in person tonight, but he promises he'll be back. I know he does. I want to thank you to all of you in the room, those of you watching live or post-live. Thank you to Penn Media for coming in and setting up all this equipment in the room and behind the scenes. Thank you to our very own Michelle Zay, whom, she's somebody who without, I would not be able to pull this programming together, not only every month, but regionally and remotely as we do. The entire GO2 team, our sponsors, and the list is long. Dr. Gandara, a huge thank you again from me. I will see you in Colorado at the end of the week. I'm really looking forward to it. And until next time, everyone, have a great evening.
See you there. Bye.
So I'll be brave if you're brave. I'll be brave, but only